Good evening, dear students. Welcome to the session. As I have been receiving the messages from you, this exam was a bit comfortable, and I believe most of the questions in anatomy you have answered correctly, and that is always a good news. The good news will be when you tell us that you have scored quite fantastically in the exam and of course cleared your Fmge barrier, so that life continues. So we are waiting for the happy ending to this whatever barrier there was, and today what we are supposed to do is discuss some of the MCQs which already came to you. So it is kind of a recall. I have gathered some of the MCQs, but it may not be complete coverage. Let us just go through the details. I will be looking at the chat as well. So right, so we are starting with the very first question here, and it is asking us about the placenta. Which part of the placenta is attaching to the maternal side? So that is one of the question we have got. Now when we talk about the placenta, it will have two components. One is maternal and one is paternal. And when we talk about the maternal component, it is the uterus which will be giving the contribution, and that is called as the decidua. And decidua also the decidua basalis component. There will be a diagram, we can focus upon that as well. But then decidua will have other parts also. As you can see in the question, there are other names, parietalis and capsularis as well. Now if you are talking about maternal side, then it is the decidua basalis which should be our answer, that is choice number B. Whereas when it comes to the fetal component of placenta, we can take this as the answer. Actually it will be the chorion frondosum, what we call it as chorion frondosum, and that will be the fetal component of the placenta. So there is one maternal component, one fetal component, and let me show you a diagram as well for better understanding. As we understand, when the baby is getting implanted, you see this is the decidua basalis we are talking about, this component. Decidua is basically the endometrium of the uterus, and if we are focusing upon the other parts of the decidua, as we can see, because it is the decidua basalis which will be contributing to the placenta. Otherwise you can see the other components here. Let me take the other color. You can find that let me just take it to this side. You can see that there is a decidua parietalis also, which is parietal, means it is at the periphery. So this will be the parietal decidua. And then there is a decidua capsularis also. So let us check this color, decidua capsularis, which will be on the uterine cavity side. But the question is asking how the baby is connected to the mother. Which part of the placenta is that? That is going to be decidua basalis. But when it comes to the fetal component, as you can see in this diagram, the fetal component is chorion frondosum. So here the finger like projections, the chorion frondosum, and that will form the chorionic plate. That chorionic plate will be then is going to meet with the decidua basalis. So here this part is the fetal component. Let us take some color here. So this part will be the fetal component, that is the chorion frondosum, and maternal we already have told it is decidua basalis. So as we come back to the question, this question was asking us about which part of placenta is attaching to maternal side. Maternal means decidua basalis, and hence our answer should remain choice number B here. Now as we proceed further, we will see that this is the next question, and as the students have told, it was one X-ray, and in that X-ray they have put one arrow mark, and that arrow mark is asking about, as you can see, mention the type of joint which is present at the marked region. So let us zoom this diagram a little bit so that we can have an idea that what they are targeting here. As you will notice, this arrow mark is actually at the first carpometacarpal joint. So as we can notice in this diagram, this is the thumb side, the first finger, second, third, fourth, fifth, 5 fingers, and this is the lower end of the radius. As is evident, this will be the radius, and that is the ulna near the wrist joint. And then we are talking about the first metacarpal, that is the base of the first metacarpal here, articulating with this bone. So which bone is this here? As we can put some other color, we understand that articulating with the radius will be scaphoid, and next to that will be trapezium. So that is the scaphoid, this is trapezium, and trapezium is articulating with the first base of first metacarpal, and that is what we are calling as the first carpometacarpal joint, saddle variety of synovial joint. And it is multi-axial joint where you can do not only flexion extension, the abduction adduction, but also circumduction. So multi-axial joints, they provide a lot of movements, and especially this rotatory circumduction type of movement, and it is a saddle variety of synovial joint. So as we understand, the answer to this question will be obviously saddle, which is actually convexo-concave. Now when you say convexo-concave, the trapezium will be x-axis and y-axis. In one axis it is concave, in the other axis it will be convex, and reciprocal articular surface will be provided by the base of the first metacarpal. So wherever you have convexity, that will be going into concavity. This is called as saddle variety of synovial joint, first carpometacarpal joint. But if you are talking about the radiocarpal joint, which is wrist joint, then we consider it as ellipsoid synovial joint because the articular surface is elliptical. So when you say radiocarpal joint, or what you call as the wrist joint proper, that wrist joint proper where you have the radius articulating with the trapezium, and this is the scaphoid, and this is the lunate. So as we talk about this joint here, it is elliptical ellipsoid synovial joint, but the examiner is putting the arrow mark here, so we'll keep our answer as saddle. Terrible triad of elbow accept was asked with options: elbow dislocation, medial epicondyle fracture, lateral epicondyle. Terrible triad of elbow. Okay, I'll have to work upon this question. I haven't got this question as such for the time being. But let us continue with the questions which I have collected, then we can move on to the things which you are adding on. Now, as I see, a lot of questions, they have come from the previous year, means it was a repeat type of, not only the topics are repeated, the questions have repeated exactly. So that would have helped you if you have gone through the previous year questions. Now, this question, as is seen in this diagram, the following anomaly is occurring due to. This is basically the skull cap is missing, cranial vault is missing, there is brain which is protruding outside, and it is not covered by the cranial vault, and it is small, it is degenerated. So if we find a small brain which is degenerated and which is exposed to the exterior because the cranial vault is missing, we are calling it as the anencephaly. Now, if this is a case of anencephaly, it is also to be understood that it is open neural tube defect, and if it is a option was like anterior tube or anterior neuropore, anterior closure defect, posterior closure defect. Okay, so if you say anterior, that will be failure of closure of neural tube cranial. Anterior means cranial. See, this is the neural tube, and neural tube is going to form central nervous system. The upper part will become brain and lower part will become spinal cord. Now this, what we are looking at is the anterior, or you can say the cranial neuropore. So this is the anterior or cranial neuropore. The other one which you see here is, let me just take it here. The other one which you see here is the posterior neuropore, and not only you can call it as posterior, but you can also call it as caudal. So cauda means tail, towards the tail, caudal, neuropore. Normally what happens is the anterior neuropore will close by day number 25, so that brain will form properly. And when it comes to the posterior neuropore should close after 3 days. After 3 days means day number 28. But you can see that may it be day number 28 or day number 25, this is 4th week. So by 4th week, these structures, these openings should close, and as the anterior neuropore or the cranial neuropore will close by day number 25, that is week number 4, then brain will form properly. And if the posterior neuropore, which is also called caudal neuropore, is closing after 3 days, that is day number 28, but still week number 4, then the spinal cord will form. Now the problem is, as you see in this case, anterior or cranial neuropore has not closed properly. So it is an open neural tube defect, and that leads to what is called as anencephaly. So in this question, if we are searching for the answer, our answer will be choice number C, failure of closure of cranial or anterior neuropore at week number 4. If it is choice number D, then what you get here is called as rachis. This is a situation which we call as rachis, which is usually with the spina bifida. Let me show you a diagram also. But choice D will be actually a case of rachis, and it will be coming along with the bifid spine. A diagram will be shown, and if it is the failure of closure of entire neural tube, then both of the things will come together, what is called as cranio-rachis. So in this particular question, we will keep our answer as choice number C, and let me show you some diagrams here. As we have discussed, in this situation, because this is anencephaly, this is non-closure of anterior neuropore. This is the rachis, where you find that there is an opening not only in the skin. You can see there is a opening in the skin, there's an opening in the vertebra, there's an opening in the spinal cord, some CSF is leaking out here. So such a scenario where you have open skin, open vertebra, open spinal cord, this is non-closure of posterior neuropore, which should have closed by day number 28, but it is week number 4 only. And if both of them come together, then we'll have this situation. This also came as a question to you, what is called as rachis. So this is a situation where we are calling it as cranio-rachis, means not only there is a problem with the brain, there is a small degenerated brain exposed outside, that is anencephaly, but along with anencephaly, we also have, you see the spines, they are not fusing, the skin is not fusing, CSF is leaking out, spinal cord is also open, that is rachis. So rachis plus anencephaly together, it is called as the cranio-rachis, means entire neural tube was open. So yes, Neelu, as you are mentioning, it is anterior neuropore closure defect, the question which has come to you, okay, this question. So in this question you should have answered, I think you already would have answered choice number C. If it was not cranial, it would have been anterior. Anterior or cranial is same in embryological development, and posterior and caudal is same as we have mentioned here. Okay, I hope things are clear now. Now coming to the next question, as I find most of these questions are usually discussed and you would have answered them correctly. Students already, they have mentioned that most of the questions were within their comprehension level and there was no aphasia. But in this question, as such. 62 means quite old age, and coming to emergency room and suspected stroke, so cerebrovascular accident. Unable to speak fluently. The patient is unable to speak fluently, and then he is capable of understanding the given instruction. So comprehension is okay, but fluency of speech is compromised. Now, if this is a situation where you find that comprehension is intact and the fluency is compromised, then we know that it is a case of Broca's motor aphasia. If it was a problem with comprehension, then we will say Wernicke's sensory aphasia. And if both of them are intact, but there is a problem with poor naming or poor repetition of language, then we will say conduction aphasia. So in Broca's, the problem is with fluency. Fluency is gone. In Wernicke's, the comprehension or understanding is gone. And in conduction aphasia, both of them are intact, but there is poor naming and the patient is having problem, like you will see there will be poor repetition of language. Poor repetition of language means you ask the patient something to repeat after yourself. You say, my name is so and so, please repeat after me, and the patient will find difficulty in repeating after you. So poor repetition, if there is a case of poor repetition, then maybe you are suspecting conduction. Global means everything is compromised. Your comprehension in the patient or the fluency is compromised. So in this question, as it appears, the answer should be Broca's. Let me just take you to this diagram as well. And in this diagram, as we understand, area number 44-45 belongs to Broca's motor area, and which is important for articulating the planning the articulation of the speech muscles. So if there is a problem with this, the patient will have hesitancy to speak, fluency gets compromised. That is what the problem was in this particular case. On the other hand, if there is a problem with area number 22, which is Wernicke's area, then comprehension or understanding of language can be compromised. And these areas, they are all supplied by the middle cerebral artery. The middle cerebral artery, which is running in the lateral sulcus here, even supplying this arcuate fascicle. And if there is a problem with the arcuate fascicle, then we can have what is called as conduction aphasia. So conduction aphasia, as I am telling, comprehension is fine, the fluency is fine, but there is a problem with the poor naming, poor repetition of language. So different type of aphasias, and if all of them are compromised, we call it as global aphasia. Now, coming back to the question itself, you see it is asking about the problem of fluency. Comprehension fine, and nothing given for naming or repetition of language. So we'll keep our answer as choice number A. Inferior frontal gyrus, area number 44-45, is supplied by branches of middle cerebral artery, and because it is a case of stroke, maybe there was some thromboembolism in the branches of middle cerebral artery, which is supposed to supply these areas. And if Broca's area is compromised, there can be problems as mentioned here. Now, moving on to the next question. You see, I have received the feedback that there was a view, lateral view of the middle ear cavity. The tympanic membrane has been removed and they are showing some of the ossicle. So maybe they were talking about malleus, or some students are telling that it was actually, this is the malleus. They were talking about, this is the head of malleus basically here. So this is the bony component of the middle ear cavity. They have put a mark either on malleus or maybe on incus, I believe, but may it be malleus or may it be incus, both of them would have come from first pharyngeal arch. So first pharyngeal arch from the neural crest cells. It is the neural crest cells which will be forming the ear ossicles, and if it is the first arch, it will form the malleus as well as incus from neural crest cells. But if it is about the stapes, then stapes come from second arch. You can remember S for S. The stapes is the smallest of all the three, and it will be coming from the second arch, though it is also coming from the neural crest cell. So neural crest cells, actually what they do is, the neural crest cells will give secondary mesenchyme, and that secondary mesenchyme will form the ear ossicles. It is the neural crest cells in this region in the pharyngeal arches. So pharyngeal arches will have neural crest cells forming secondary mesenchyme, and in the first arch will have malleus incus. I think it was marking on malleus, or could be incus, both of them will be in the first arch, but stapes, if they mark, then it is not a very clear diagram as such for me, and I don't know which kind of diagram was given to you, but if it was marking on stapes, then it will be second arch. Marking was on incus. Fine then. If it is malleus or incus, first arch is your answer. And then I believe there was a question which is asking you some details about what is called as the this area, pre-auricular sinus. So if they are asking you about pre-auricular sinus, and the question was asking, why would you get such a case? And some students are telling that even some pus was coming out of this area. Now, if it is a case of pre-auricular sinus, it is something to do with the auricle and development of auricle. Auricle develops from 6 hillocks. We will see a diagram for that. And these hillocks, they develop in the first as well as the second arch. Sometime these hillocks, they may not be fusing with each other, and that could be a problem leading to this kind of anomaly, that is pre-auricular sinus. So how many hillocks are there? 6. 3 from first arch and 3 from second arch. Let us first look at a diagram so that we can have some orientation, then we can come back to this discussion again. So as I am mentioning, let me zoom this a little bit more. During development, what happens is, for the external auricle development, the first arch is giving 3 auricular hillocks, and as you can see, the second arch is giving the other 3. So total 6 will be there. Though it is in the new books, in the new embryology books, it is mentioned that the first arch contribution towards the auricle is very little. As you can see, the first arch is contributing very little, only tragus part in fact, and rest of the auricle is developing from the second arch. The point is, if there is a non-fusion of the contribution by first arch with the second arch, means the problem somewhere here in this region. Means if there is a non-fusion of the auricular hillocks given by first arch and the second arch, then there can be pre-auricular sinus developing. So I think that choice was available with you. If there is a non-fusion of the auricular hillocks given by first and second pharyngeal arch, then there can be a case of pre-auricular sinus. So tell me, incomplete closure, yes, of course, but choices were, how the choices were given? Hillocks were mentioned, or just the arches were mentioned? If hillocks are mentioned, then there is no issue at all. But if arches are mentioned, you can say non-closure of, failure of closure of the fusion of arch 1 and arch 2 derivative. That can lead to this pre-auricular sinus. So this was your case. Let me rub this off so that things become a bit clear to you. This is one opening in front of the tragus of the ear, and it happens because the auricular hillock contributory first arch and second arch, they have not completely fused properly, and in due course of time it may have some mucus, some pus infection can happen, some pus can be coming out of that. So some students told that they have mentioned about the pus as well. Now as we move on to the next question, this question I have received a lot of other details, like they have mentioned about one tubercle also, which is called Chesegnac's tubercle. So was there a mention of Chesegnac's tubercle as well in the question? Okay, options were first and second pharyngeal arch incomplete closure, second, third, first and second pharyngeal pouch. So it is not a pouch problem, not at all. It is a problem of pharyngeal arch, and if it is pharyngeal arch, then 1 and 2. So Neelu, as you are mentioning, the answer will be first and second pharyngeal arch incomplete closure. That will be the best answer. First and second pharyngeal arch incomplete closure. It has nothing to do with the pouches as such when you talk about preauricular sinus. So common carotid artery, so as I see IMG is telling there was no mention of Chesegnac's tubercle. Anyway, you should know about this Chesegnac's tubercle as well, because questions can come. So common carotid artery pulse you want to take can be taken in carotid triangle. And where is carotid triangle? Carotid triangle will be in front of this sternomastoid muscle, and there are a lot of landmarks here which can be used, but let me take you to a diagram that will be let me add some information here only. There is a Chesegnac's tubercle, and what is that? That is at the C6 vertebra. In the C6 vertebra you will have one anterior tubercle, and on that anterior tubercle you can palpate or take the pulse of common carotid artery, and this is C6, so cricoid cartilage. And how do you find cricoid cartilage? The most prominent structure here is the Adam's apple, thyroid cartilage. You feel the thyroid cartilage, go below that, you will have a ring here, cricoid cartilage. So that prominent thing, more prominent in male, but is prominent in female as well. So the prominent thing here is the thyroid cartilage. Below that there is a ring shaped structure which is cricoid cartilage. You have to go lateral to that and then lateral to trachea. Though trachea begins little bit inferior, means cricoid cartilage, after that is trachea. So go lateral to the larynx or trachea, and there as you go lateral, if you compress, don't do it on both sides simultaneously, only one side. You can do carotid sinus massage also, carotid sinus massage, but that is a little bit higher. In fact, if you want to take the pulse, you could compress the common carotid artery on anterior tubercle of C6 vertebra, Chesegnac's tubercle, and a very good place where you can take the carotid pulse. So as I mentioned, cricoid cartilage is C6 vertebra posteriorly, and cricoid cartilage or C6 vertebra level, you have anterior tubercle of C6 vertebra where you have anterior tubercle, and that anterior tubercle is Chesegnac's tubercle. Let me show it in a diagram as well. But here I believe the answer should be choice number A, cricoid cartilage. Cannot be the sternal area, it is too low, and suprasternal means it is still in the midline. One artery is yet to be given, and that is common carotid artery. Lot of details, but I believe the answer should have been cricoid cartilage, and the diagram which I am talking about is here. So as you will notice in this diagram, we are focusing upon the cervical vertebra. This is C7 actually, C6, 5, 4 like that. On the C6 you see this is the Chesegnac's tubercle. Let me zoom a little bit more so that you can see the details. This is the C7, this is C6, and these cervical vertebra, they have anterior and posterior tubercle. As you can see, there is one anterior tubercle, one posterior tubercle on the transverse process. There is a body, there is a transverse process, anterior tubercle, posterior tubercle. The anterior tubercle of C6 is maybe on this side or maybe on this other side. You can actually feel the common carotid artery. Don't feel them simultaneously because they are carrying blood not only to head and neck but also to the brain. You should do it only on one side. There you can compress the artery, and the diagram which we have on the side, let me say, you are looking from the front view. As I mentioned, what the first thing you have to do is feel for the prominence of this thyroid cartilage. Go below that, and as you go below that, this muscle is also there, sternomastoid. Go anterior to that because it is carotid artery in the carotid triangle. Now as you see, this is on the left side, this is the common carotid artery coming here and bifurcating here. It bifurcates at the superior border of the thyroid cartilage of the larynx, and posteriorly it will be C3, C4 vertebra. So if you go to the highest border, superior border of the lamina of the thyroid cartilage, that will be C3, C4 posteriorly, and that is where common carotid artery will bifurcate. As you can see, it will be giving external carotid and internal carotid. So this is external, that is internal, but that happens at a higher level, and you have to palpate or take a pulse of common carotid below that. So where? This is the cricoid cartilage we were talking about, and you have to go lateral to that. As you go lateral to that, this is the artery. As you go lateral to that, this is the artery. So this is the point where you can compress common carotid artery at the level of C6 vertebra or cricoid cartilage and against the Chassagne-Neck's tubercle. I hope things are clear now. If it is the laryngeal prominence, superior border of the lamina of thyroid cartilage, that is where common carotid artery would have bifurcated into two branches, that is external and internal carotid artery. But you are supposed to take the pulse of common carotid, so you have to be a little bit lower, and that is at the level of cricoid cartilage. That was your question, and this is your answer. Sir, you haven't taught the muscles of the face and face. What is this? Sir, you haven't taught the muscles of face and face in head and neck. Muscles of face. But you have studied from which source? Because if you are talking about muscles of face and face in head and neck, it will be coming at random places. Say for example, when we talk about facial palsy, that time I will be talking about muscles of face like orbicularis oculi, zygomaticus muscle, orbicularis aureus muscle, vaccinator muscle. So it may not be a specific topic where I have taught, because you know, if you try to cover all the topics, then the coverage of the videos, it becomes too much and you repeat things at multiple places. So what I do is, some things I will skip and mention them in other topics, so there can be overlapping of topic. That is why I am asking that what was your source of study material. But I do teach muscles of face, but not in details because nobody is asking. Like I will talk about occipitofrontalis muscle, but occipitofrontalis muscle I will be talking about in facial palsy, Bell's palsy, or maybe in scalp region. But there will not be a topic where it will be just, you know, muscles of face. That topic is not there. I don't teach like that. So maybe you are correct, but then you should have gone through entire syllabus. Then maybe you will not. Then you will find that I do teach muscles of face, but at random places, wherever I find it is important. Okay, so yeah, thank you very much for all the appreciation. Our purpose is not only, you know, to make you clear this FMG exam, but also to make you a good doctor. You are the budding doctors, you are our future, and it is our duty that not only we should train you for clearing the exam, but to become a better physician and a surgeon. So as we see this particular question, answer, the only answer I can think of is, because it is common carotid artery, cricoid cartilage, C6 vertebra, compressing it on Chassagne-Neck's tubercle. And as we proceed further, again what I find is a lot of these questions, they are repeated topics, And it is good that most of the students who have given us feedback, they are telling they could answer things quite correctly. So this is about the epidural anesthesia, and when you talk about epidural means you are not supposed to puncture the meninges, and whatever meninges is given should be your answer because it is asking not punctured. So I will show you a diagram where we can talk about the layers when you do the epidural anesthesia puncture, but because you are outside durameter, you are not supposed to touch the any meninges. So arachnoid mater you are not supposed to puncture, that should become your answer. And of course you are going through the supraspinous, interspinous, ligamentum flavum, all those ligaments when you push your needle for maybe epidural or maybe even lumbar puncture. And showing you the diagram here, let us look at this diagram. Let us first start with the spinal cord itself. So as you see, this is the spinal cord which is terminating at the lower border of L1 vertebra if it is an adult. In adult situation, the spinal cord will be terminating at the lower border of L1 vertebra, but the pia mater which is covering it will continue downward on filum terminale, and then it will be attaching to the C1, that is coccygeal 1 vertebra. So maybe the spinal cord will terminate, but the pia mater which was covering the spinal cord will not terminate, and pia mater will cover what is called as some collagen fibers, filum terminale, and that will be attaching to coccygeal vertebra. Now this is the pia mater. Over that you will have the arachnoid mater. As you trace the arachnoid mater, this arachnoid mater will continue down but stops at S2 vertebra level. So this is S2 vertebra level where it will be stopping, and that is the arachnoid mater, S2 vertebra level. And when it comes to the next meninges, that is the dura mater, the one which is still outside, you can trace the dura mater. You see, this is the dura mater which is still outside, and that dura mater is not stopping at S2, it will come down, cover the filum terminale, and it is reaching the coccyx level. So even the dura mater has to reach the coccyx level. So as I repeat once again, you see the very first thing is spinal cord covered by pia mater. Where is the pia mater reaching? The coccyx bone. And what is the next meninges? That is the arachnoid mater. Where is the arachnoid mater stopping? It stops at S2 vertebra level. Under that there is subarachnoid space, and that subarachnoid space filled with CSF will also be stopping at S2 vertebra level. Sometime you want to aspirate the CSF, and if you want to do that, as you can see in this diagram, there is a needle, lumbar epidural and lumbar puncture. If you do lumbar puncture, then of course you will have to puncture dura mater as well as arachnoid mater. But that is not your question. Your question is epidural, means you are supposed to stay outside dura mater. And if you are staying outside dura mater, you are not supposed to puncture any of the meninges. And what exactly are you puncturing then? What you are puncturing can be seen here. The very first thing you puncture is the skin, and after skin you have superficial fascia, and after that supraspinous ligament. You see here, let us change the color. This is supraspinous ligament. Then there is one interspinous ligament. This is interspinous, and then still deeper you have ligamentum flavum. So the very first thing, skin, then superficial fascia, supraspinous, interspinous, ligamentum flavum, and then you will reach the epidural space. There you can inject the anesthesia. That will be epidural. But if you go still deeper and puncture the dura mater and arachnoid mater, then you can aspirate the CSF and you can do what is called as lumbar anesthesia. In your question, it is epidural, means you are outside dura mater, and in that procedure you are not supposed to puncture any of the meninges. What you puncture is just the skin, superficial fascia, supraspinous, interspinous, and ligamentum flavum as given in this sequence. Just that. So I hope you get the idea. Sir, they gave intraspinous and not interspinous. Intraspinous. What is intraspinous? Intraspinous. Intraspinous, intraspinous. Intraspinous ligament, maybe some clerical error, misprint, but it should be interspinous. There is no intraspinous name as such, as far as I know, as per my knowledge. Maybe some printing mistake then. Intraspinous. Some new terminology, neologism is coming up. So sometime it happens, clerical error, we call it as clerical error, printing mistake. Computer, ज़माना कंप्यूटर का है, कहीं गलती होगी, पर ऐसा नाम मैंने मतलब इस कॉन्टेक्स्ट में तो नहीं सुना. यहाँ पर सिर्फ इंटरस्पाइनस होता है, इंट्रास्पाइनस तो नहीं होता. माफ कर दो उनको. आपका आंसर तो मिला कि नहीं मिला. आपको ड्यूरामेटर पंक्चर नहीं करना है और एरेक्नॉइड तो करना ही नहीं है अगर आप एपिड्यूरल एनेस्थीसिया दे रहे थे. तो आपका क्वेश्चन ये है यहाँ पर, जैसे आप देख सकते हैं, इट इज एपिड्यूरल एंड बिकॉज यू आर गिविंग एपिड्यूरल यू आर नॉट सपोज टू पंक्चर एनी मेनिंजेस, not durameter, not arachnoid mater. So the only possible answer is choice number D. Arachnoid layer. Arachnoid layer को आपको puncture नहीं करना है. Okay, right. So as we move further, you see, I can tell you all these questions are repeat questions and repeated in last 5 years. This is a repeat question, maybe somewhere in 21 I believe. So that is our advice to the students, that you should keep practicing previous year questions at least 5 years. And what do you think is your answer here? So as we can find, see, first of all, it could be a dissected specimen or it could be an MRI or maybe some other radiographic picture. Only thing is you have to understand that what is the orientation. If it is a CT scan or MRI, usually inferior to superior. So this will be inferior to superior, that means this is the vertebral body and this is the spine of the vertebra, the transverse process, and articulating with transverse process you can see this is the rib, multiple sections of rib can be seen, and if you go more anterior this is the sternum. So sternum anterior and vertebra, the thoracic vertebra, because you see they are talking about the chambers of the heart. So if they are talking about the chambers of the heart, you should always read the options also, means you are in the thorax. In the thorax this is thoracic vertebra, and then these are the ribs. If these are the ribs, this is the sternum anterior, this is lung. This must be the right lung because you are looking inferior to superior, so this is right lung and this is the left lung. Now once you have discussed about the lungs, between them is mediastinum, and in the mediastinum you have the middle mediastinum. In the middle mediastinum you have the heart, will have 4 chambers. You should remember when we do transesophageal echocardiography, what is the first chamber you see? That will help you in this discussion. See, this is the vertebra. In front of the vertebra you will find there is esophagus, and you are putting a probe in the esophagus. What is the first chamber you see? That is left atrium. This is the left atrium. Now if you say this is the left atrium, fine. What about the other chambers? So this is the left atrium here. You can see pulmonary vein also coming. Now the thing is, related with the sternum, whatever chamber you see, let us take some other color. Related with the sternum, whatever chamber you see, the sternocostal surface of the heart, sternocostal, sternum and the ribs, sternocostal surface of the heart is right ventricle. That is right ventricle. Now if you say this is the right ventricle and that is the left atrium, then what about the other chambers? You have to understand the right border of the heart. You have the right atrium, the right border of the heart. Let us change the color now. This right border of the heart is the right atrium. So this will be the right atrium, and if it is the left border of the heart, it is left ventricle. So left border of the heart, left ventricle, right border of the heart, or right atrium. So where is left ventricle then? As you search for the left ventricle, this will be the left ventricle. So this is left ventricle. Let me show you this same thing in another diagram, but in this question, if they have put a mark here, the posterior most chamber of the heart, then it is left atrium. This is the left atrium, choice number B. Now the discussion goes quite detailed. It is all based upon embryology, but just to simplify the things I have given you, see, first of all, the diagram which is given to you is a transverse section, feet, the head, inferior to superior. And the same thing they can give in dissected specimen also. Maybe they have given dissected specimen and students are telling it is black and white. There is no purpose of giving dissected specimen with and then making it black and white, doesn't make sense. So dissected specimen should be given colored. But anyway, maybe it was not dissected specimen, it was a radiograph. In any situation, if you repeat the information again, let me zoom this diagram. Can you see the anterior most structure which you find here is the right ventricle. This sternocostal surface is right ventricle. You cannot see left atrium at all because left atrium is the posterior most. If you talk about the right border of the heart, it is right atrium. Left border of the heart, left ventricle. So left ventricle, where is the left atrium? Behind. And this is the diagram, kind of diagram which you have there. So the most posterior is the left atrium, most anterior is the right ventricle. If you talk about the right border of the heart, it is mostly right atrium. If the left ventricle, it is the left border of the heart. And the same story, the four chambers can be seen there. If I zoom this dissected specimen, let us check your knowledge now. If we are looking at this diagram and in the option there are four chambers of the heart given, means it is a question on the dissected specimen of the chambers of the heart. The first thing which you should do is look for this bone, that is sternum, and related to sternum, sternocostal surface, whatever chamber you see here must be the right ventricle. If that is right ventricle, which is the most posterior related with the esophagus, this is esophagus here. So related with esophagus, this must be the left atrium. And if it is left atrium, inferior view, then what is this chamber here? This is the right atrium. And what is that chamber here? That is the left ventricle. And one more thing which you can appreciate is the thickness of the muscles in the left chamber is quite thick as compared with the other chambers like right ventricle. So if you compare the thickness, this is 3:1 because this is pushing the blood into systemic circulation throughout body and this is pushing the blood into the lungs nearby. So if I rub it off, you can see the difference as I am trying to explain that look at the thickness of the wall of the, let me take this color. Now you see, look at this thickness and look at this thickness. So you can see yourself that right ventricle is thinner, 3 times thinner as compared with the left ventricle. So this is left ventricle, this is right ventricle, this is right atrium, and the question was on left atrium. I hope, yeah, near vertebra, it is left atrium. Pathological right ventricle hypertrophy. Okay, Aditya, sorry to interrupt you, but if the pathological right ventricular hypertrophy, ventricle section can confuse. Yes, but then the examiner will mention that it is a case of right heart failure or right ventricular hypertrophy. If they do not mention, if nothing is mentioned, we have to take it as normal anatomical specimen. Of course, I agree, things will change, like in tetralogy of Fallot, things will be totally different. Or if it is, right ventricular congestive heart failure, things can change. I agree. If it is not right ventricle as it was left atrium, bro, in exam, asked you could confuse, they get prone. Was it prone position or supine position? Why would they give prone position? They have given prone position. Hypertrophic. See, if it is hypertrophic ventricle, they will mention it definitely in the stem of the question. They will give some idea at least. Prone position. They should not give any prone position, and even if it is prone position, then you have to train yourself. You have to look for the vertebra basically. Say, if you want, I can make it prone also, but the thing is that this body of the vertebra should be identified. In front of that, esophagus is not very clear here. This is the aorta, descending aorta. So this is on the left side of the vertebra, descending thoracic aorta. This is descending thoracic aorta, and this is the vertebra, left atrium. Then you will see sternum. Later with sternum is right ventricle. So that is right ventricle with sternum, and that is the left atrium with the vertebral body. If you go here, this is right atrium. If you go there, this is the left ventricle. So that is how you can actually, if you look at the schematic diagram, you can see the same orientation here. With vertebra, you will have the descending aorta on the left side, and just approximated on the vertebra will be left atrium. The right ventricle will be approximated to the sternum, that is what we call sternocostal surface, and then this is the right atrium, that is the left ventricle. Means again you have to practice a lot of questions, then you become comfortable. Body of vertebra upside. Who is this examiner? What is the purpose of giving a prone posture diagram to students? Who is this? They are giving that diagram which is, okay, they want to confuse. Why are you not confused in the beginning itself? See, MBBS students are confused, lot of students. This man is having some sadistic nature then. Sadism. Why would you give a diagram which is prone posture and dissected specimen, or maybe who is this is very funny, very clever. No, he is not clever. He is cunning. There is a difference between clever and being cunning. Shrewd means he is not a good man. Whoever, man or woman, whoever. But anyway, that is what we keep telling the students. Practice as many MCQs as possible so that you understand the psychology of the examiner, so that you can tackle his psychology also. Maybe these people, they can cross any boundaries. Doesn't make sense giving a prone posture. But who gives, have you seen any radiograph which is prone unless otherwise they specify, or there are some specific condition where you have to keep the patient prone? Nobody gives any diagram which is in prone posture. Anyhow, even if it was prone, you would have to search for the vertebra, and if the arrow was close to that, left atrium. That's what I believe the question was, and that is what I have answered. Then we have to just reverse the diagram if it was prone. Even not in INI-CET exam. Yes, INI-CET people are at least some, they have some wisdom. Don't do this BS. This is called BS. You know what is BS? Very strange. And I think again a repeat question. I believe the examiner was just, but not all examiners are like that. Not all examiners are like that. There can be aberrations, you know. So have faith in this world, in people of this world. There are good people. If they were not good people, then the world would have crashed long back. So there are few people who are aberrant. Don't bother. Maybe you just have to tolerate them. So I think the examiner was putting one arrow on this tendon, which is coming from the posterior forearm, and we call it as the extensor pollicis longus, as you can trace, it is going to extend the pollex attaching to the base of the distal phalanx here, and if you use it, you can extend the pollex like this. So posterior forearm muscle, extensor pollicis longus, and it is extending the thumb. That is why the name is extensor pollicis, and it's a long tendon, so longus. And you have to understand that it is actually passing through this region where you will have on the dorsal aspect of the radius, lower end of the radius, Lister tubercle. So it is actually making it, it is called Lister tubercle, and Lister tubercle, it will go around that. It is kind of using it as a pulley. So going medial to, now you have to be careful, what is medial, what is lateral? Thumb is lateral, little finger is medial. So medial, this tendon has to go medial to dorsal tubercle of Lister. This tendon, when it is coming from here, it is going medial to dorsal tubercle of Lister, and then it is going to extend the thumb. So this extensor pollicis longus also forms the medial boundary of anatomical snub box that you already knowing. So this is the anatomical snub box, and if you go posterior medial to that, this is basically posterior and medial. So posterior medial boundary of anatomical snub box is one tendon, extensor pollicis longus, and if you come to the anterolateral boundary, now be careful when I say anterior and lateral, this is anterior and lateral. So in the anterolateral aspect you have two tendons, but the first answer to this question, if they ask you anterolateral boundary, should always be extensor pollicis brevis, because for abductor it is AAA. It is additional, the abductor is additional and more anterior. So for, if you say abductor pollicis longus, then you should know it is AAA, means abductor is additional boundary and it is more anterior. The actual boundary is extensor pollicis brevis. So this anatomical snub box is bounded by two extensors, extensor pollicis longus, which is posteromedial, and extensor pollicis brevis, which is anterolateral. Though we also include abductor pollicis longus, and then you know those signs we have. If you remember, we keep on discussing, these two tendons can be involved if it is D. quervain tenovaginitis. These two tendons, one short and one long, can be involved if it is D. quervain tenovaginitis and this Finkelstein test positive, all that. So pain on the anterolateral boundary, two tendons involved, Finkelstein test positive, all those questions keep coming. Okay, so as such I think it was a simple question. Just examiner just wanted you to identify the extensor pollicis longus, which is posteromedial boundary for the anatomical snub box. And this is again a repeat question. Now if some student tells me, sir, this is not a repeat question, then I'll tell you one thing only, like I tell my son, that if you say this is not a repeat question, that means you have not practiced the previous year questions properly. It's a repeat question. I remember I have discussed it. I have not even prepared a new slide. This is the old style, lot of slides in this discussion are old slides because they are repeat, the questions are repeated. Normally we say topics are repeated, these questions are repeated. So anyway, for the person who has practiced, who has answered correctly, he'll be comfortable, but the person who has not answered correctly, and he will be feeling frustrated and angry at me. He will be angry at me. What, sir? You are telling we have not practiced questions properly. But we make mistakes. Let us hope that mistakes don't cost us dearly. Means everybody make mistake, but we should minimize our mistakes. So what do you think? It is just you have to ask the patient to make a grip, and means tight grip, and some tendons will be becoming prominent. As you see, there are some 5 muscles in the anterior forearm, and those 5 muscles, again, I don't want to go into details of everything here, but the point is, if it is towards the radius bone, means towards the thumb side, you have radius bone, and you will have, because this is all flexor muscles, so they flex the carpus, hence the name. First of all, towards the thumb side, so radius, and because they are flexing the carpus, flexor carpus radialis. So when you say this is a tendon which is the flexor carpus radialis, then where is flexor carpus ulnaris? It will be towards the ulna side, towards the little finger. So towards the little finger we will have the ulna, and on that you will have the ulnaris. So this tendon, if you focus upon this tendon, that will be flexor carpus ulnaris. Now why should the name be carpus? Because they insert on the carpus and they pull the carpus. They are inserting on the carpus and they pull the carpus. That is how the wrist is flexing. So flexor muscles of the carpus. 5 muscles, pronator teres, flexor carpus radialis, then in the middle you have palmaris longus, the one which is also making what you call as the palmar aponeurosis. So this palmar aponeurosis modification of the D fascia is the flat tendon of the middle tendon here, what you find, and that is palmaris longus, a very thin muscle, but this middle one is palmaris longus. So the one which is right in the middle is palmaris longus. The one which is towards the thumb side, radius side, is the radialis, flexor carpus radialis. The one which is towards the little finger and towards ulna bone is flexor carpus ulnaris. And if you want to search for FDS, flexor digitorum superficial, it's a bulky tendon and slightly deeper. It may not be so well felt. So only 3 tendons become prominent when you do this kind of thing. And towards the radius, flexor carpus radialis, towards the ulna, flexor carpus ulnaris, in the middle, palmaris longus. And if you are looking for the flexor digitorum superficialis, you will feel, but your thumb will go into depth, and there you can find even flexor digitorum superficialis, this thing, but it is difficult to feel just like that. You will have to push your thumb deeper. These 3 tendons, they are quite prominent. So I hope you have answered it perfectly fine. Yeah, we try our best to make you people comfortable with anatomy, and all the appreciation is well received. If we were unable to help you, then there is something wrong with us. That is the way I think. So we have to, improve ourselves so as to, reach your level, so that take you from there to our level, and then you go beyond also. You will become very good surgeons, very good physicians, but in the process you have to go through anatomy, and trying our best it will definitely help you. And the purpose, I told you, the purpose is not only just to make you pass the exam. The purpose is to make you a better doctor, better physician, better surgeon, better human also. That is why in between somewhere I'll start talking some philosophy. You should be a better human. Actually, you should be a better human first. Then only you can become a better doctor. So, as we can see, because first of all we can just mark the 3 tendons, 1, 2 and 3. So this is towards the thumb, so flexor carpus radialis. Choice number A should be our answer here. Okay. Now as we proceed further, I think there was some diagram given to you, or maybe some explanation given to you, and this anterior abdominal wall defects they keep asking. So in the anterior abdominal wall defect, sometime they'll ask you about the Meckel's diverticulum, or sometime they'll ask you about umbilical hernia, sometime they will ask you about gastroschisis, and this was your question, I believe, on fellow seal. So as I understand, the students are telling that it is a midline pouching of intestine, maybe some liver also, covered by amniotic membrane, and umbilical cord is normal. So that kind of presentation, if it is omphalocele. Omphalocele is a midline protrusion of intestine along with maybe liver, and umbilical cord is not normal. Umbilical cord is not normal because it is inside the umbilical cord you have this intestine and liver covered by amniotic membrane. Versus if you say gastroschisis, in gastroschisis umbilical cord is normal. Umbilical cord is normal. It is to the right side of umbilical cord that there is a defect, anterior abdominal wall defect, and from there some intestines are coming out, but they are not covered by amniotic membrane. So if intestine are protruding out, intestinal herniation on the right side of a normal umbilical cord, and the protruded viscera is not covered by amniotic membrane, then it is gastroschisis. And if it is just a simple umbilical hernia, then you will have the skin covering it. Skin is covering. Here you do not have any skin covering. Here you do not have any skin covering. So if skin is covering it, then it is umbilical cyst or umbilical hernia, which could be normal protrusion of omentum, maybe omentocele, not necessarily intestine. It could be just omentum. And that is Meckel's diverticulum. That is another story where you have persistence of vitalo-intestinal duct, the midgut diverticulum. Normally the midgut diverticulum, what is called as Meckel's diverticulum, should disappear. But if it is persisting, then in the terminal ileum, there will be a diverticulum. Sometime it can be diverticulum, sometime it can become a cyst, or it can become a fistula. If it is a fistula, fecal matter will keep coming on the umbilicus, fecal fistula. So Meckel's diverticulum or Meckel's cyst, Meckel's sinus, frequent questions for you in FMGE. And if it is a Meckel fistula, then the terminal ileum sending fecal matter to umbilicus, persistence of vitalo-intestinal duct. So, and one other thing which comes is exostrophy of urinary bladder. That is not a diagram given here, but anterior abdominal wall defect only. The urinary bladder is open outside. Exotrophy of urinary bladder. So that is also one of the anterior abdominal wall defect which the examiner keep asking. But I think your question was on omphalocele, covered by amniotic membrane, midline swelling, and these patients, they'll have multiple congenital anomalies: cardiovascular defect, neural tube defect, chromosomal defect. Multiple congenital anomalies will be seen. Okay, right. Yes, Magesh, as you are mentioning, that's what the feedback is, that the anatomy was easier. So it happens like sometimes few subjects they appear easier, and they keep on changing. It is kind of a randomized thing. Sometimes PSM, like I believe last time PSM was difficult. So they keep on doing this. But I personally feel that as compared with the previous exams, this time anatomy was a bit comfortable for me also. Like otherwise I can detect that okay, they have made it tougher, but I don't feel like that. So it's good for you, isn't it? And there was a question on conjoint tendon. Again, repeat question. So it may not be exactly the way they have asked earlier, but it's a repeat topic basically. So what we understand is, when we talk about this inguinal region, let us focus upon the front view of the right inguinal region. So front view of the right inguinal region, the very first muscle you will see is external oblique muscle and flat tendon. You call it as external oblique aponeurosis. So the one which you see here, and in which you have an opening also, what is called as the superficial inguinal ring, through which the spermatic cord will come out. So the very first muscle which you remove is external oblique muscle, and external oblique muscle is the one which will be having a flat tendon, so you say external oblique aponeurosis, and will have an opening superficial inguinal ring, and through which the spermatic cord will be passing. If you remove this, deep to that is internal oblique muscle. So this is internal oblique, and internal oblique muscle you will find is not only anterior to the spermatic cord, it is also roof of spermatic cord, and it is also going posterior to spermatic cord. Now, when you say it has such a relation with the spermatic cord, which is arching fibers, internal oblique is anterior, roof and posterior. You can say it is also the boundaries of inguinal canal, because spermatic cord is running in the inguinal canal. So internal oblique is in the anterior wall of inguinal canal, roof of inguinal canal, and posterior wall of inguinal canal. Now, if you compare it with the next muscle, which is the transversus abdominis, because there are three muscles normally we talk about: external oblique, internal oblique, and transversus abdominis. If you come to the third muscle, transversus abdominis, it is only roof, it is only, let us take some other color, it is only roof and posterior wall. So the difference between transversus abdominis and internal oblique is, internal oblique was anterior, superior and posterior to the spermatic cord, but the transversus abdominis is only superior and posterior, and when it goes posterior, that is where together they will form what is called as central tendon. So conjoint tendon, sorry. So conjoint tendon means two muscles coming together. So which two muscles coming together? They are the internal oblique and transversus abdominis. And where do they come together? They are coming together in the posterior wall of the inguinal canal, or behind the spermatic cord. So behind the spermatic cord, in the posterior wall of inguinal canal, you have two tendons merging, and that is why it is called conjoint tendon. And it is important because it is preventing any viscous, say urinary bladder, from protruding out, preventing direct inguinal hernia, which is more common in elderly patients. So elderly patients, we find the direct inguinal hernia is more common, and maybe urinary bladder trying to enter into inguinal canal, inguinal hernia. So elderly patients where abdominal tone is less, maybe the urinary bladder was undergoing direct herniation, that will be prevented by this conjoint tendon. So conjoint tendon, which is two muscles together, namely internal oblique and transversus abdominis, they are preventing this urinary bladder to move further into inguinal canal. They are protecting, they are preventing the direct herniation of urinary bladder. So I exactly don't know what kind of, but these 4 or 5 statements students have mentioned, that kind of question came. Yeah, previous year topic it is, yes. Conjoint tendon forms posterior wall of inguinal canal. Yes, that is correct. The conjoint tendon forms posterior wall of inguinal canal is correct. If you talk about the internal oblique, it is forming anterior wall, roof and posterior wall. If you are talking about transversus abdominis, then it is just forming roof and posterior wall. And if you are talking about external oblique muscle, it is forming anterior wall and also floor. The external oblique will form anterior wall and also floor, because at the floor it is modified to form inguinal ligament. So external oblique is anterior wall and floor. At the floor it is modified to form inguinal ligament. The internal oblique is anterior, roof and posterior. The transversus abdominis is just roof and posterior, and when both posterior come together, they form conjoint tendon. Yes, correct. Milad Ashraf, very correct. This is a true statement. If conjoint tendon reinforces the superficial inguinal ring, you can see this is superficial inguinal ring, which is in the tendon of external oblique muscle. So it is a defect, and through that defect the urinary bladder can come out, forming inguinal hernia. So urinary bladder was trying to come in elderly patient through this opening, but it was prevented by conjoint tendon. Correct. This statement what you have written is conjoint tendon reinforces the superficial inguinal ring. Correct. Conjoint tendon continues in inguinal ligament. Conjoint tendon continues as inguinal ligament. No. It is the external oblique muscle which will form the floor of the inguinal canal, and that is what is inguinal ligament. Inguinal ligament is a modification of external oblique muscle to form the floor of inguinal canal. And conjoint tendon is not related to inguinal ligament as such. Inguinal ligament is floor and relates to external oblique muscle, whereas conjoint tendon is posterior wall and relates to internal oblique and transverse abdominis. So as such, if this is a statement you are telling conjoint tendon continue as inguinal ligament, no, that's a wrong statement. Okay. So I think these 4-5 choices were there. I could not get the proper. Yes, always in your service. Thank you for all the appreciation. And again, I should not continually tell, otherwise some students will get irritated that what for every question sir is telling it is a repeat question, but it was a repeat question. Hasselbeck's triangle and hernia. See, again, they are. Do you understand what is the importance? See, first of all, let me tell you that we are continuing with this right-sided inguinal region front view, right-sided inguinal region front view, right-sided inguinal region front view. This Hasselbeck's triangle is the one from where the urinary bladder was trying to come out, direct inguinal hernia. That urinary bladder was trying to come out through Hasselbeck's triangle only. That is the region where direct inguinal hernia comes out. And who was preventing it? Like you already have mentioned, it was prevented by conjoint tendon. Because in front of that we have the superficial inguinal ring. There is a defect. And into that defect the urinary bladder was trying to enter via this. So if a structure comes to this region, then we will call it as direct inguinal hernia. But if the structure comes through this region, then we will call it as indirect inguinal hernia. So what is the boundary line between the direct inguinal hernia protrusion and indirect inguinal hernia protrusion is inferior epigastric vessels, which are themselves coming from external iliac vessels, which they become femoral vessels. In the femoral triangle, you will have femoral vessels, but they are continuation of external iliac vessels. And these external iliac vessels, what did they give to enter rectus sheath? To enter the rectus sheath, they give inferior epigastric vessels. And that was your question. Question was, in Hasselbeck's triangle, what is the superolateral boundary? Superolateral boundary, inferior epigastric vessel. And what is the floor? Floor is inguinal ligament attaching the pubic tubercle to the anterior superior iliac spine on the hip bone. On the hip bone, you have anterior superior iliac spine, and coming to the pubic tubercle is inguinal ligament. So base is inguinal ligament. And what is medially present? There is this rectus muscle and rectus abdominis, the lateral border of rectus abdominis. So if you are talking about, this is, what is this? Rectus abdominis, medial border of the triangle, medial border of the triangle. So this is the triangle. Means if you want to look at the boundaries, you should tell lateral border of rectus abdominis, inferior epigastric vessels, and inguinal ligament. This is Hasselbeck's triangle. In Hasselbeck's triangle, you have inguinal ligament, which is a modification of external oblique aponeurosis. and then it is related with the lateral border of rectus abdominis muscle, and then it is related with inferior epigastric vessel. I think in your question the choice was inferior epigastric vessel, they wanted to know, and that is where the urinary bladder was trying to come out, or omentum is coming out, omentocele, vesicocele. So omentocele, vesicocele in elderly patients where the tone of abdominal muscles is low. If it is young boy, then hernia comes here. Young boy, congenital. So young boy, congenital, it is indirect inguinal hernia, and again intestine can come, or omentum can come, omentocele or enterocele, but that will be lateral to these vessels. These vessels, which vessels? If the hernia is protruding through the deep inguinal ring, if it is coming through a deep inguinal ring, then it is indirect, and if it is coming medial to this, then it is direct. And this is altogether different thing, femoral hernia. It will be inferolateral. Femoral hernia are inferolateral to pubic tubercle, where the inguinal ligament attaches. So inguinal ligament is attaching, it is in the thigh, it is in the thigh. In the thigh and inferolateral to pubic tubercle is femoral hernia, more common in females. Superomedial is the inguinal hernia. So superomedial are inguinal hernia, and inferolateral are femoral hernias. Inguinal more common in males, femoral more common in females. Okay, question was all border except. So, okay, then I think inguinal ligament will be one option. Lateral border of rectus abdominis will be one, and inferior epigastric vessel will be one, and whatever the fourth one is would be the answer of exception. Okay, now yes, I think even this question they have asked after a long time, but then you should know that congenital diaphragmatic hernia is one favorite topic in your Fmge exam and all exams in fact. This is the inferior to superior view in a transverse section development of diaphragm, inferior to superior view of the developing diaphragm, and I think they have asked you about the dorsal mesentery of esophagus. When the diaphragm is developing, it is developing from four sources, and what they have asked you is the dorsal mesentery of, see this is esophagus, and esophagus will have a dorsal mesentery, dorsal, because this is vertebra, vertebra is to the dorsal side. So towards the vertebra, towards the dorsal side, you have esophagus giving dorsal mesentery, and that dorsal mesentery of esophagus forms the crus of diaphragm, which is basically right crus and left crus of diaphragm attaching to lumbar vertebra. So esophagus will have a dorsal mesentery. Why you need mesentery? Mesentery is double fold of peritoneum to carry blood vessels or nerves. So esophagus was having some blood vessels coming, and those blood vessels may have been coming through this dorsal mesentery of esophagus, and but later it gets modified. So dorsal mesentery of esophagus gets modified to form right crus, left crus of diaphragm attaching to lumbar vertebra posteriorly, contributing to diaphragm. Otherwise diaphragm has other contributions also, like in the diaphragm you will find there is a central tendon of diaphragm which is coming from a septum separating thorax and abdomen in embryology. In embryology there is a septum, a transverse septum which separates thorax from abdomen. So that is the one which forms central tendon of diaphragm. So septum transversum forms the central tendon of diaphragm through which passes the inferior vena cava at T8 vertebra level. I'll repeat again. Embryologically there was a septum transversum because it is a septum which is transverse. So septum transversum which will form the central tendon of diaphragm, separating the heart from the liver. Heart from the liver. Heart is in the thorax, liver is in the abdomen, and then it is through which the inferior vena cava is passing at T8 vertebra, because liver, behind liver is inferior vena cava. Liver drains into inferior vena cava. The structures which are under diaphragm, they drain into inferior vena cava. So structure under diaphragm, lever, drains into inferior vena cava by lever veins, and then this inferior vena cava must enter the heart. But how it will enter the heart? By puncturing central tendon of diaphragm and at T8 vertebra. Where was this esophagus passing through diaphragm? Esophagus passes through the diaphragm at T10 vertebra. And where is aorta? T12, bounded by the two crura. These two crura will form opening for the aorta, aortic opening. So right crust, left crust of diaphragm, they will be forming an opening, aortic opening, and that is at T12. So aorta passes the diaphragm at T12, esophagus passes at T10, and inferior vena cava passes at T8, T8, T10, T12. Sometime we remember it by this mnemonic: voice of anatomy. V is inferior vena cava, O is the esophagus, A is the aorta. So voice of anatomy, V T8, O T10, A T12. So 8, 10, 12. The three major openings in the diaphragm embryologically. So voice of anatomy 8, 10, 12. Voice of anatomy 8, 10, 12. Though I don't use such mnemonics very frequently, but can be helpful sometimes. And one other thing which is important here is the pleuroperitoneal membrane contributing to a small peripheral part of the diaphragm on either side. It is deficiency of left-sided pleuroperitoneal membrane which can result in congenital diaphragmatic hernia or Bochdelic hernia. So in the diaphragm there are four components, and in the four components you have pleuroperitoneal membrane also. Pleuroperitoneal membrane, what is it doing? Separating pleural cavity from peritoneal cavity embryologically. Embryologically, there was a membrane separating pleural cavity from peritoneal cavity, pleuroperitoneal membrane, one on either side. And what does it contribute? Diaphragm. What is the purpose of diaphragm? Separate thorax from abdomen. And if the left pleuroperitoneal membrane is deficient, if the left-sided pleuroperitoneal membrane is deficient, stomach can move into thorax. The intestine or stomach can move into thorax, what is called as Bochdelic hernia, congenital diaphragmatic hernia. So why do we get congenital diaphragmatic hernia? Due to deficiency of left-sided pleuroperitoneal membrane. And the fourth component is cervical myotomes. Cervical myotome, because we know that this diaphragm is a skeletal muscle. Diaphragm is a skeletal muscle. So from where the skeletal muscles come? They come from cervical somite. That is why the root value of diaphragm is C3, 4, 5. Now you might think that diaphragm is having muscle from cervical region, then why it is here? Because it descends down, carrying the nerves also. Diaphragm develops here. Later it descends down. Septum transversum develops here in the neck. Septum transversum was in the neck, later descend down. As it descends down, it will carry the nerve also. Which nerve? Cervical nerve. Which cervical nerve? T4, 5, phrenic nerve. That is why phrenic nerve, a nerve of neck, supplying structure almost in the abdomen. How come? Because the diaphragm was never there. It was here. It has descended down, carrying the nerve also. So where is this smooth muscle coming from? Cervical somites. Cervical somites. They are muscles from the neck which are in the forming the skeletal muscle of diaphragm. Now why I am stressing so much upon this? Because again, as we say, it is the topic which is repeated. But anyway, I don't think it will be of any use to you for your Fmge exam. You already have cleared your exam, take it from me. If you are sticking still with me, bearing all kind of tortures, then you are some devoted people and you would have already cleared your Fmge. But you'll become a good pediatrician. In pediatrics, you'll remember me back. That yes, sir used to tell us, and we still remember. So good. Because that is the way I tell. And that is the way you should read, learn. And there are very few faculty who, first of all, they don't have the knowledge, and second, if they have the knowledge, they are unable to express, and even if they want to express, there is no time. Students are not interested. But I think you people are interested a lot, and you will definitely become very good doctors. Maybe you become pediatrician, pediatric surgeon, gastroenterologist, or gastro-thoracic surgeon. Now, maybe someday you might remember back, there used to be some professor in anatomy used to tell us something, and it is still useful, because that is how you should be taught. In fact, there is a problem with our teaching. Teachers should be like this. Students will automatically become better. We cannot blame you, because the problem is on our side. How can you blame the recipient? You are the end user. If end user is not efficient, that means there is something wrong at the giving end. Anyhow, let us hope things will change. And again, I have not changed anything at all. I have just removed the year from here, because it's a repeat question. It is a repeat question. Orthopedic surgeon, yes, fantastic. Magesh, very good. Sure, my best wishes are with you. Definitely, you should become not only expert orthopedician, but do some MCH, some Master of Cardiology in orthopedics. In orthopedics also, like Dr. Apurv, he is one of my friend, close friends. So he is very good at TKR, total knee replacement. Sometimes, in professional world, you change teams. So you may change teams, but that doesn't mean that you will forget your old connections. They should remain there, and they should grow stronger with time. So what do you think? I think maybe this was the diagram, or whatever was the diagram, but the examiner wanted you to identify a plane which is below the costal margin, 10th rib, below the 10th rib, subcostal plane. And if it is the subcostal plane, means below the costa means the rib. So where will it be? Actually, in the abdomen, the very first thing we do is we put one midline like this and like this. Then we say we are 4 quadrants: right upper quadrant, left upper quadrant, the right lower quadrant, and left lower quadrant. This is the basic thing. Through umbilicus, we'll put 4 quadrants. But this is more than that, 9 regions. So for 9 regions, you'll have some planes. And let me take you to those planes. But this is subcostal plane. Now, if it is subcostal plane, sometimes some authors, they use another plane, which is slightly higher, not the 10th rib. It will be higher at the tip of 9th costal cartilage, called transpyloric plane. So sometimes they use the transpyloric plane also, but mostly you should remember subcostal plane. Okay, so where is transpyloric plane? L1. If that is higher in L1, then where is this? L3. So remember, I think this was your question. They wanted you to answer subcostal plane L3. And let me take you to the same. So in this question, I think the examiner wanted you to mark this option here, L3, subcostal plane. And let me just go to this diagram. It is a diagram taken from Gray's Anatomy, the actual Gray's Anatomy. There are so many Gray's Anatomy these days. Originals, they get lost, and copy-paste people become famous. So anyhow, even the copy-paste people should understand their responsibility and should behave responsibly. So this is what I am talking about, that there will be a subcostal plane just below the 10th rib, costal margin, And then there is a transtubercular plane. Transtubercular plane. Now, transtubercular plane means it is on the hip bone. There is this anterior superior iliac spine. From anterior superior iliac spine, you go slightly posterior, there will be a tubercle, and through that tubercle there is a plane, transtubercular plane. And this, if you look at this, this is the mid-clavicular line on right side, mid-clavicular line on the left side, and it also passes through midpoint of inguinal ligament. So midpoint of inguinal ligament or midpoint of clavicle. So right mid-clavicular line, left mid-clavicular line, or middle of clavicle touching the midpoint of inguinal ligament here in this region, creating 9 quadrants. These are the 9 quadrants. This is the umbilicus here. Remember, umbilicus, just behind umbilicus will be L3, L4 vertebra, disc between L3, L4. So if umbilicus is disc between L3, L4, if umbilicus is at the disc between L3, L4, you can just understand what will be this level and what will be this level. If this is subcostal plane, it will be higher to this, and if this is below the transtubercular plane, it will be lower to this. So that is how you can just remember, because umbilicus is L3, 4, you go higher L3 and go lower, then it is, or you can see this diagram here, that will be better. See, it is the comparative diagram, as it, because you know our memory is photographic, so it is always better to use diagrams, the appropriate diagrams. So this is transumbilical plane, which is disc between L3, 4, that is umbilicus. Now if you go higher to that, upper border of L3, it is the subcostal plane, which the examiner has asked you, and if you go lower, it is L5 upper border, which is transtubercular plane. So the umbilicus is disc between L3, 4. If you go higher, L3 upper border is subcostal plane, and if you go lower, L5 upper border is transtubercular plane. So these are the planes which normally we are using. Midline, this is the mid-clavicular line, right, and this is mid-clavicular line left. So total 9 quadrants. If I make it the other color, maybe to make it more evident. So I think these 4 planes we should remember, but then I have seen some of the authors, they don't use subcostal plane, they use transpyloric plane. And if we are using transpyloric plane, then it is at the tip of 9th costal cartilage, L1 lower border. Tip of 9th costal cartilage, that is where you do Murphy sign also. Murphy sign, touch the gallbladder. If acute cholecystitis, painful. So at the tip of 9th costal cartilage, transpyloric plane, where you have pylorus of stomach also. Because you have pylorus of stomach, that is why it is called transpyloric plane. So transpyloric plane, tip of 9th costal cartilage, L1 lower border. A lot of things happen here. One is fundus of gallbladder, and as I'm telling, like if you remember, termination of adult spinal cord, L1 lower border. So L1 lower border, transpyloric plane, pylorus of stomach, fundus of gallbladder, tip of 9th costal cartilage, Murphy sign, acute cholecystitis, or termination of adult spinal cord. All of these are MCQs. But the examiner has asked you subcostal plane, so L3 upper border. So was it subcostal or transpyloric? Because the students, they told it was subcostal. It depends, like what kind of image was there. I think it was image based question. They gave a line midway between umbilicus and xiphisternum. They gave a line midway between umbilicus and xiphisternum, asked its vertebral level. Okay, xiphisternum, and then it should be transpyloric. Then it should be transpyloric. If that is the story, a line midway between umbilicus and the xiphisternum, then it must be transpyloric. L1. Then it will be L1. What do you think? Then it cannot be subcostal. That means the information which I got here has to be modified. So as you are telling, this line was not here. This line was actually between umbilicus and xiphisternum, midway. And if it is midway, then definitely the examiner was talking about where you do the Murphy sign, or transpyloric plane, or the L1 should be your answer. In that case, L1 should be your answer. If according to you, the line was at a midpoint of umbilicus and xiphisternum, then cannot be subcostal, cannot be L3. Then they must be talking about transpyloric plane, and that must be, then the answer should change to L1. If that was the condition given. Okay, then let us say it was 9-quadrant division of abdomen. Yes, even 9 quadrants of abdomen can be done using transpyloric also. So be careful. That's what I was telling. Some authors, they don't use subcostal plane. Instead, they use transpyloric plane. And using transpyloric plane and this transtubercular plane, they are dividing the abdomen in 9 quadrants. See, my point is, normally, according to convention, you should use subcostal plane, but nobody is doing that. Then what are they doing? They replace this with transpyloric and still divide the abdomen in 9 quadrants. Yes. How divide the abdomen in 9 quadrants? By putting mid-clavicular line, and transpyloric plane instead of subcostal plane, and the transtubercular plane. So many authors, they don't use subcostal plane at all. You look into B.D. Joshia or look into this Vishram Singh, they don't have this diagram at all. What they use is transpyloric plane. So that is what I was wondering, that the examiner has asked you transpyloric plane or subcostal plane. But as I can make out now, Miss Teacher, yes, if it is subcostal plane, then she will be telling you L3, and that is fine. But then one of your friend is telling that it was a line which is midway. See, if it is L3, it will be just superior to umbilicus. But if it is a line which is between xiphisternum and umbilicus, then it must be transpyloric, and then the answer should change to L1. So it depends again, like where was the line given. Okay, all teachers will teach you perfectly fine, they have good knowledge, but depends, like any change in the question might change the answer. That is why topics are more important than the questions. So I hope whatever you have marked was correct answer. That is the final statement I can give. And see, I have just changed the year. I have not changed the year also. Repeat question. It's a repeat question. So tell me. They are showing lesser trochanter. And if they are showing the lesser trochanter, maybe when this question came first time, some students may have answered, some may not have answered. But the point is, you are not supposed to make mistakes in repeat questions. It is not acceptable at all. So you should practice previous year questions so much that you should not make mistakes in repeat questions. Maybe when the question came first time, some people could answer, others could not. Even when I found this question, I was thinking, what are they asking for? But once it has come and once we know that what they are asking, then we cannot make mistakes. So, okay, cannot make mistake, but what is the answer? It is two muscles coming together. And what are the two muscles coming together? It is iliopsoas, iliacus and psoas major. Iliacus and psoas major. And if you have on YouTube only, you will find those videos I have discussed using this diagram. So, the muscle which we are talking about, this is front view, lumbar vertebra. From the lumbar vertebra, you are having this muscle, the psoas major, coming and inserting on lesser trochanter. Not only the psoas major will come, which is coming from lumbar vertebra and then inserting on the lesser trochanter of the femur, but it is accompanied by this other muscle which is on the inner side of iliac part of hip bone. Inner side iliac part of hip bone, hence the name iliacus, and it is also inserting here. And since they cross the hip joint anterior, they pull the femur anterior. They cross the hip joint anterior, they pull the femur anterior. If you pull the femur anterior, you are doing hip flexion. This is the chief muscle of hip flexion. Flexion means folding, folding of hip joint. Since these psoas major and iliacus muscle, they cross the hip joint anterior, they pull the femur anterior. If you pull the femur anterior, you will fold the hip joint, flexion. The chief muscle of hip flexion antagonizes gluteus maximus, which is the chief muscle of extension. It crosses hip joint posterior. So iliopsoas is the chief muscle of hip flexion, will antagonize gluteus maximus. And gluteus maximus is the chief muscle of hip extension because it crosses posterior. It will pull the femur posterior. If you pull the femur posterior, extension, and that is done by the gluteus maximus. So where is gluteus maximus attaching? Gluteus maximus attaches posterior on the femur. But where? There is a gluteal tuberosity, but posterior. So posteriorly the upper femur. Posteriorly the upper femur will have gluteal tuberosity for attachment of gluteus maximus, which will pull the femur posterior, doing the hip extension and antagonizing iliopsoas, which is chief muscle of hip flexion. Okay, right. So in this question, our answer we have marked is iliopsoas. I think that is all I could gather. Okay, there was one, yeah, this question. This question was there. Now, sometime it may happen, like, though I find it very uncomfortable that students telling, sir, let us do rapid revision and let us revise everything. It's very difficult to revise everything. And if it was possible to revise everything in 4 to 6 hours, then why should we have 40 to 60 hours of videos? So it's difficult to revise everything from the teacher point of view. But from the student point of view, you have to revise. So where do you get all these diagrams then? Of course, if you have been following PrepLadder notes. This is a diagram from PrepLadder notes only. Just now I have taken it out. But the point is that have you really watched that video? And if you have watched that video, do you really remember? And so it is not exactly specific points. It's kind of a network. Maybe your radiology teacher would have taught you. Sometime in between, I am teaching this, but in other context. So, but I think this was quite a easy question for you as far as I believe, because the examiner was just pointing and asking that mark the lever. This is lever. Inferior view, because CT scans are usually taken inferior to superior. So on the right side you will have lever. Then they were marking the spleen, which is on the left side. And then I think they have marked the pancreas. This is the pancreas going towards the spleen because it has to reach the hilum of the spleen. So it runs transversely, that is the pancreas. This is the vertebra posteriorly, the body of the vertebra. Near to that will be the kidneys. Very much approximated on the vertebra will be kidneys. So just for the orientation, and actually I remember for you people only, they had given this diagram, and what I have discussed in previous year questions, they gave you portal vein, inferior vena cava and hepatic veins. So that question I remember, which I have discussed myself, that they gave portal vein branches, and they were also asking you to identify inferior vena cava. Inferior vena cava is simply remembered by the fact that if this is the vertebra, inferior view, on the left side will be aorta and on the right side will be inferior vena cava, because it is embryologically like that. Inferior vena cava, superior vena cava are on the right side of the body. Aorta is on the left side of the body. So aorta on the left side, IVC, SVC on the right side, embryologically. So that is aorta, abdominal aorta on the left side, because looking from inferior, this is left side. So left side you will have abdominal aorta, right side you will have inferior vena cava, and still more anterior you will have the portal vein. So this is portal vein. And sandwiched between the inferior vena cava, portal vein, you will have the caudate lobe of lever. Caudate lobe of lever. So portal vein anterior, inferior vena cava posterior, sandwiched will be caudate lobe of lever. So that kind of question came earlier, that I remember. But in this time I think examiner was in a good mood, I believe, whoever decided the final paper, and gave you, now I cannot say it is simple, even to identify liver and pancreas and spleen is not so easy, at least for an MBBS student. But comparatively, if you start talking about segments of liver, comparatively this is easier question, isn't it? Segments of liver, caudate lobe of liver, 4A, 4B, then things get detailed, and they have already asked such questions. So comparatively this is easy. Okay. So I am very confident that within a week you will be enjoying like anything, because definitely not only in anatomy, I have seen other subjects also. A lot of students, they have given correct answers, and that's what we wanted eventually, so that you cross this hurdle and continue further with your journey as a doctor. Start preparing for PG entrance. Our wishes are with you. May God bless you with all the courage, hard work and good luck, and we are with you always. Okay, I'll stop here. Take care. I'll try to find out some other questions as well, so that if something is left where I can contribute, definitely I'll do that. So, V for victory. Taking a leave now. God bless.